Good morning, everyone. Welcome to the second day of this meeting, where we are celebrating the anniversary of the 25 years of conduction system pacing, his pacing mainly. This session is going to be fully in English, but if you have any question in Spanish, we'll be able to respond in both languages. Okay. It's for me a pleasure, an honor to be here. So I would like to thank Pablo for the invitation to be here and moderating this interesting session. But I would like to thank also not only Pablo, but also Pepe, Rafael, all the team for the opportunity they gave to me of learning directly at the hospital in 2006, the opportunity to learn how to pace, not only how to pace, but how to do it well, how to pace his bundle, okay? That was an amazing experience that changed for me my vision forever, my vision of cardiac pacing, so thanks to God. And now I'm going to introduce my mate, Guillermo, from the hospital Reina Sofía in Córdoba. Good morning, Guillermo.
Good morning, everyone. So we start without more delay. The first talk will be given by Dr. Ermengol Valles from the Hospital de Mar in Barcelona. Title: do we have enough data to change our approach in pacing CSP after action?
Good morning. Good morning to everyone. My name is Ermengol Valles from Hospital de Mar in Barcelona. I'm very happy to share my work, and I would like to thank Dr. Morina for giving me this opportunity. Today I'm going to talk on the topic, do we have enough data to change our approach in pacing, CSP as a first option? 10 years ago, conduction system pacing was proposed as an alternative to classic CRT for patients with a reduced ejection fraction. But what some of us may not know is that first reports of CSP date back from the 70s, represented, of course, by his bundle pacing. And then this technique started to grow up from the shadows, and since the beginning of the century, it's being more and more important, and Dr. Morina has been one of those investigators more active in the field. The idea was to capture the conduction system to restore the normal activation of the ventricles, and then with this shorten the QRS duration, similar to what we aim with the CRT, but in a more physiological manner. Having said that, as you all know, CRT is cornerstone for the treatment of heart failure in patients with reduced ejection fraction. It was first described more than 20 years ago, and it has demonstrated incredible results in terms of survival, cardiovascular admissions. Besides, CRT is superior not only to optical medical treatment, but also is superior in patients with an ICD implanted. The problem is that CRT is not working for everyone, just 70% of responders. Back to CSP, here's where we are so far. During the last 10 years, a bunch of observational studies have been published describing first the non-inferiority and then afterwards some of them superiority of CSP over CRT. And finally, from 2019, some randomized studies came out to confirm all those observational findings. His same trial and his alternative trial have proven that his stimulation is equal or even better than CRT in terms of QRS duration, echo response, and New York Heart Association class. On the other hand, we have the left bundle branch pacing. This technique is the most used to perform CSP nowadays, and similarly to his bundle pacing, it has proven to be at least equal to CRT in randomized trials. Level AT and LBBP resank have shown similar improvements in terms of echo response, hospitalizations, QRS duration, and New York Heart Association class. Having said that, one can argue all those big trials have a modest sample size. And it's true, but all of them go in the same direction. And importantly, big registers like MELOS have been crucial to confirm those findings and to develop for the development of the technique. But what do we have to do in patients with a normal ejection fraction? Are they candidates to CSP instead of a right ventricle apical pacing? As a reminder, patients with an bradycardia indication are the biggest target for cardiac pacing. They are the vast majority of patients receiving a pacemaker. Besides, this type of patients, for technical reasons, are more likely to get a successful CSP procedure. Answering the question, during the last years, some observational studies have been published, but no randomized studies have been performed so far. And that's why they get this as a CSP indication only achieves an indication to be as an alternative to right ventricle apical pacing when we are performing the strategy pace and ablate or for AB block with normal ejection fraction and stimulation, expected stimulation of more than 20%. Now, I think this situation, it can change. It's about to change. Today, I present the first randomized study comparing CSP to right ventricle apical pacing in patients with a bradycardia indication and a normal ejection fraction. This article came out a few months ago in Circulation Arrhythmias, but I think more studies like ours are still to come, and probably this can establish the basis to consider CSP for everyone. State trial was a randomized study comparing CSP versus right ventricle apical pacing. Among the inclusion criteria, the most important were having an ejection fraction of more than 40% and having a high degree AB block with anticipating a high burden of ventricular pacing. Among the exclusion criteria, the most relevant were having an indication for an ICD or CRT or a previous left ventricle dysfunction. The primary endpoints were the evolution of the left ventricle ejection fraction and diameter, and secondary endpoints were the admissions due to heart failure or atrial fibrillation. We also studied the New York Heart Association, NT-proBNP, and Minnesota Quality of Life Questionnaire. This is the flow chart for the study. More than 400 patients were evaluated, and finally 75 were finally randomized. Among patients not meeting criteria, the majority of them had a low expected BP burden, and some of them also had a current previous left ventricle dysfunction or were candidates to ICD or CRT. Among the randomized patients, 35 were randomized to right ventricle apical pacing. Of those, 3 were lost at follow-up. 1 died for a non-cardiovascular cause. And among the 40 patients randomized to CSP, 1 was lost at follow-up, and 4 crossed over apical pacing due to failure. That's the 10% failures. I think it's consistent with the literature. Finally, the intention to treat analysis included 31 patients in the right ventricle apex arm and 39 patients in CSP arm. And these are the results. There were no differences in the population, in the characteristics among both groups. Basal average QRS duration was 137 milliseconds, so that it was a sick patients with a impaired AB block, expecting a high burden of ventricular pacing. Average left ventricle ejection fraction was 60% in both groups. In terms of procedure, acute results, the fluoroscopy time and acute thresholds were slightly worse in the CSP group, but the difference were not relevant. Importantly, the pace QRS duration was 160 milliseconds in the right ventricle apex group compared to 124 milliseconds in the CSP group. Finally, almost 70% of the CSP group received a left bundle branch area pacing with an average LVAD of 82 milliseconds. And these are the main findings at 6 months follow-up. With a ventricular pacing burden of more than 90% in both groups, left ventricle ejection fraction decreased by 6.6% in the right ventricle apical pacing group, while it remained stable in CSP group, meaning a difference of almost 6%. The reduction in the left ventricle diameter was also significant but less evident. And of note, these echo improvements were also supported by a decrease in 17% reduction in the absolute risk for heart failure admissions. In the views of this study, and I think the studies to come, I would expect CSP to be the new gold standard for patients with a high degree of AV block and a normal ejection fraction. I'm talking about normal ejection fraction now. And for this to happen, we need that the CSP technique become affordable, easy, and reproducible. I think left bundle branch area pacing gather all those characteristics and could be the first option in patients with a normal ejection fraction. Therefore, my next steps in the talk and in the research have been affected by this idea. And I must warn you, some of you may not be in line with these thoughts. I think we can, you don't have to use your EP recording system. So I don't think, I'm not saying you don't have to do it, but you may not do it. In other words, you may not do it. These are the 2023 consensus for left bundle branch pacing criteria. There is no doubt this is a remarkable work, and it establishes the basis nowadays for left bundle branch pacing performance. But what if we simplify this algorithm in order to reach smaller centers and more population, and you can use the criteria with a simple PSA? What if we focus on the LVAT? Maybe some of here are not in line with this, and maybe also V6 to V1 into peak time. Those criteria only uses V1 and V6 in the EKG. We have performed a non-randomized observational study to assess the left bundle branch capture criteria with the PSA and compare it with the EP recording system, placing the white lead, which is the unipolar lead in a 5 leads PCA, in V1, and moving down the yellow lead, which is AVL, to V6. Then we assess the left ventricle, left bundle branch capture with the EP recording system, with the criteria being having a right bundle morphology in V1 and the accomplishment of the LVAD criteria or the B6 to V1 criteria. And finally, we have compared those results with the PSA. This study is in process of publication, but I can advance the results are very positive. Quick example, in a patient with a left bundle branch block, we plotted the electrode start pacing, and you can see the pace morphology is very similar in V1 and V6 in the EP recording system and PSA, with exactly the same duration. Same for the LVAT, similar duration, and the same for V6 to V1 in peak time. The second one, here comes my second idea, which is even more provocative. Do not use your criteria. Let me explain before attacking. State trial has demonstrated that left bundle branch area pacing preserves normal ejection fraction and prevents admissions for heart failure compared to right bundle apical pacing in the setting of a high BP burden. The problem is not all left bundle branch area pacing are the same. Criteria to assess left bundle branch area pacing distinguish those cases in which left bundle branch is captured from those in which only the muscle surrounding the left bundle is captured, which is left ventricle septal pacing. Left ventricle septal pacing reflects a less specific type of stimulation, but on the other hand, it can be easier to achieve. On the other hand, recent observational studies have shown contradictory results in relation to the performance of left ventricle septal pacing compared to left bundle branch pacing in patients with a low left ventricle ejection fraction. Some of they say they are equal. The majority of them say left ventricle is worse than left bundle branch pacing. Agree That can be true, but it's still contradictory. But what about patients with a normal ejection fraction? I believe it's reasonable to think that left ventricle septal pacing can work as good as left bundle branch pacing in those patients with a normal ejection fraction. And today, there is no data at all regarding the efficacy of left ventricle septal pacing in patients with a normal ejection fraction. So that's why State 2 trial has been designed to answer this question. State 2 trial is still in process of recruiting centers. It's going to be a multi-center prospective randomized parallel control study in patients with a more than 40% of ejection fraction. They are going to implantation due a high degree AV block. Randomization will be in a 1-to-2 fashion, right ventricle apical pacing versus left bundle area pacing, and data will be loaded to an electronic CRF and after the procedure, including the left bundle branch area pacing criteria accomplished, and after each control, including clinical echo parameters. The thing is, the singularity of this study and cornerstone of the study is to accept the first location with the right bundle branch morphology in V1 during stimulation, as long as the thresholds are optimal. Criteria for left bundle branch pacing versus left ventricle septal pacing will be evaluated after the procedure, and operators will be banned to any other lead but V1. Patients allocated in the left bundle branch area pacing arm will be implanted following an anatomical approach, aiming for the W pattern in V1 and conversion into a QR or RSR during septal penetration, of course, with the help of the current of injury and the impedance drop. And this is my last slide to take home messages. CSP has demonstrated to be similar to CRT in patients with a reduced left ventricle ejection fraction. CSP is better than right ventricle apical pacing in patients with a normal ejection fraction. The left bundle branch area pacing could become the gold standard technique to stimulate any patient. Therefore, it should not be restricted to all hospitals with a EP unit, since it can be performed with a PSA. Left bundle branch area pacing is not a homogeneous technique. Left bundle branch pacing could be better than the left ventricle septal pacing for patients with a CRT indication, but there is a lack of evidence regarding the capabilities of left ventricle septal pacing for patients with a normal heart. And the left ventricle septal pacing might represent an easier and faster technique with similar results, maybe, in these patients. Thank you.
Thank you. Good morning. First of all, I would like to thank Pablo and the industry to have the possibility to be here, not to be here alone, also with my wife. This is a beautiful village. I don't know if I'm able to speak after the dinner of yesterday, but thank you again. And to be here with friends and with very important people in the area of the anatomy. Can I see the slide, please? Well, we are going to see what are the anatomic determinants during or for conduction system patient. We are going to see that it's depending on not only how is the anatomy and the histology of the penetrating AV bundle conduction system, and how it is depending on the technique, because the technique is different to the core valve, for example, or Sapiens transaortic valve implantation. I am not able to see still the slide. And second, we are going to see how are the arrangement of the penetrating AV bundle in relation with the two components of the membranoseptum, the atrial connections the atrial and the interventricular component of the membranous septum. Then, how is the aortic root? How is the penetrating AV bundle in relation with the atrial and interventricular membranous septum? And how is the technique during transaortic valve implantation are going to be an important anatomic determinant during transaortic valve implantation. Here you can see two dissection of how is the aortic root in relation with the right ventricle, the right AV junction, and how is the relationship of the aorta in relation with the area where the penetrating AV bundle appear in the subaortic root, in the so-called left ventricular outflow tract. In the left, you can see that the aorta is protruding into the right ventricle and dividing the component between the outlet and the inlet. This that you can see here, this is, I don't know if you can see, yes, this is the supraventricular crest. And how is the anatomy of the atriointerventricular membranous septum in relation with the supraventricular crest? And when you go to the right, to the left ventricle, we have the mitral-aortic continuity. We have this continuity between the outlet and the inlet. Therefore, how is the position of the aortic root in relation with the right AV junctions and the left AV junctions? Here you can see in these dissections, we have removed the endocardium of the compact AV node and the central fibrous body here. And you can see how is the intramyocardially located right bundle branch, and this is the supraventricular crest. Therefore, if we want to understand how is the anatomic relationship between the penetrating AV bundle with this supraventricular crest, we need also to go to the left side to see how the His bundle and the variable His bundle appear in the left ventricular outflow tract. Here you see the left bundle branch, and this is the aorta protruding into the right ventricle in between the inlet and the outlet. You know the position, the crossing position between the right and the left ventricular outflow tract. Therefore, the two components of the membranous septum, the fibrous membranous septum, the atrial and the interventricular component of the membranous septum, here you can see the compact AV node, and by transillumination, the atrioventricular and interventricular component of the membranous septum. It is the septal leaflet of the tricuspid valve, the attachment of the septal leaflet of the tricuspid valve, who divide both components, the atrial and the interventricular component. Please note in this dissection, by transillumination, you see the area of the His bundle. I don't know if, no, the arrow is not working. By transillumination, you can see the vertex of the triangle of Koch, also the fossa ovalis. Note, with my finger is the septal leaflet of the tricuspid valve. You can see the orifice of the coronary sinus, and this area is in close anatomic relation with the left ventricular outflow tract. If we want to understand how is our implication for conduction system patient in the left ventricular outflow tract in the aortic root, we need to understand how is the variable dimension of the membranous septum and how is the variable area where the His bundle penetrating AV bundle to the non-branching and branching area. The penetrating AV bundle is variable within the area of the triangle of Koch, with the AV junction, as you can see in this dissection. Please note that the compact AV node in the left is in a lower position, in the right is in the superior position as a result of different dimension of the membranous septum. The dimension of the membranous septum, atriointerventricular membranous septum, mark how the AV bundle penetrate in the right side of the right side of the AV junctions to go to the left. Therefore, it's depending on also of the right side how the His bundle appear in the left side. This, you know, this previous study that they demonstrate is by studying the interventricular membrane of septum, different positions, more deeper and more inferior. And in this video, you can see, just to understand what is the area, this is the muscular interventricular septum. Please note that this is the atrio-interventricular membrane of septum, the attachment of the mitral valve annulus, the lower attachment of the tricuspid valve annulus, and here you see the area where the His bundle penetrates through the atrio and interventricular membrane of septum. To understand the variability of the membrane of septum is crucial, and this is like a fingerprint. We have a range of dimension, we have a range of deep, we have a range of lead, but this is like a fingerprint in each heart. And this is the result of the variable position of the His bundle. Here you can see in the left by right atrial angiography, you can see the display of the tricuspid valve annulus. And you know very well when you are doing His bundle pacing, or when you are doing ablation of the slow pathway or mid-septal accessory pathway ablation, you know how is the variable position of the comparative, you know, at the inferior extension in the right AV junctions. And on the right, you can see how is this position in relation with the more atrial, more annular, or more septal position, or more ventricular position. Here, please note that this is the origin of the penetrating AV bundle. From an histological point of view, the concept of penetrating AV bundle is when it's completely surrounded by the connective tissue of the fibrous body, the central fibrous body. And here you can see that this is the penetrating AV bundle, the septal leaflet. Here is more atrial, here is more at the level. And here, please note the penetrating AV bundle and the septal leaflet. In this position, the penetrating AV bundle is in the ventricle. It's in the ventricular aspect of the tricuspid valve annulus. Therefore, atrial, annular, and ventricular aspect also is crucial. In this left ventriculography, you can see that we are going to try to understand how is the area of the penetrating AV bundle in relation with the left ventricle. And note that this is the so-called mitro-aortic continuity. This is the aortic leaflet of the mitral valve, and this is the mural leaflet of the mitral valve that is posterior, and this is non-coronary sinus of the aortic root, and this is left, and this is right. You know that the non is posterior. And this is the area of the His bundle recording site, and this is the inferior, this is superior, and this is anterior, just to understand what is the attitudinal orientation. The aortic valve is not an annulus. You know that this is the virtual annulus, and here you can see the area that corresponds to the sinotubular junctions, the aortoventricular junctions, and the virtual annulus. To understand how is this anatomy of the aortic root in relationship with the membranous septum is crucial, because the penetrating AV bundle that we have seen before have different position in relation with the supraventricular crest. In this video, you can see the aorta and the mitro-aortic continuity. Please note that you can see the superior and inferior papillary muscle, the superior and inferior group of papillary muscle, and the area that corresponds to the non and the attachment. Therefore, this is the area of the penetrating His bundle. And look my finger in relation with the right ventricular outflow tract, because we are going to have some anatomic reference in the right side to reach the subendocardial aspect of the left ventricle. Therefore, to understand how is this position also is crucial. Let's go here to this slide just to show that this is the right side. Note the penetrating AV bundle by transillumination. This is non, this is right, and this is left. This is the mitro-aortic continuity, connecting both the right and the left fibrous trigone. And please note this area. This is the area of the membranous septum. Therefore, if we want to understand how are the anatomic determinant during transaortic valve implantations, depending on how is the device, if the device is just CoreValve or Sapiens, how is more superior or more inferior? Well, it's depending on how is the variable position of this membranous septum, the interventricular membranous septum, and the area, in fact, of the central fibrous body, the area where the His bundle penetrates. In this simulated thoraxis, you can see a tricuspid valve, aortic, pulmonary artery, that this is anterior. Note the left atrial appendage, the narrow mouth of the left atrial appendage. This is the aortic leaflet of the mitral valve. That is anterior. This is the mural leaflet of the mitral valve. This is the orifice of the left atrial appendage. Note now that this is the right side. This is the septal leaflet of the tricuspid valve, anterior and inferior. And this is the aorta. We are going to open the aorta like a book, and you are going to see that we have the posterior or non-coronary sinus. This is the area that corresponds to the triangle of Koch. This is the vertex of the triangle of Koch. And note how is the anatomic relation, this area that corresponds to the membranous septum, and now the area that corresponds to the mitro-aortic continuity. Therefore, all this area of the left ventricular outflow tract, mitro-aortic continuity, and membranous septum is crucial if we want to understand where are we working in this area. You can see in the middle that this is the non-coronary sinus. I am not able to see the laser, but you can see on the right, you can see the orifice of the right coronary artery. This is the right coronary sinus, and in the left. Therefore, note that in between the non and the right, you can see the area that corresponds to this, the attachment of the leaflet, independent attachment. This is not an annulus. We have myocardial content within the sinus, and there you can see the membranous septum and the right fibrous trigon. This is the mitro-aortic continuity connecting both right and the left fibrous trigon, and this is the left ventricle. You can see the anterior and close. You can see what is posterior, what is red, what is left, and what is right. Then this is the area that corresponds to the membranous septum. Look my finger, and in connection with the atrioventricular membranous septum. This is the area of the triangle of Koch. This is the vertex. This is the area of the His bundle. And this is the area, my finger again, in relationship with the left ventricular outflow tract. Crossing positions. But this is the area of the membranous septum. Look again, my finger showing the area of the membranous septum. And this is not as simple like the membranous septum is the area where the left bundle band arises. There are an important anatomic variability of the interventricular membranous septum in the attachment of the left ventricular tract. You can see this is posterior. And by transillumination, please note by transillumination, this is the interventricular membranous septum. The fibrous membranous septum with the two components, atrio and interventricular membranous septum. But this transillumination is from the right side, from the right atrium, from the vertex of the triangle of Koch. Then, if we want to understand how are the variability, because you know that the site of AB block, most of these patients after transaortic valve implantation is mainly infranodal. And you know, I'm sure that the next speaker will be about what are the anatomic determinants and patient-related, age, more than 75, female, a smaller left ventricular outflow tract, previous QRS duration, the presence of calcification, but also the depth of valve implantation, how is the balloon predilatation, if we use core valve or we use Sapiens. We need to understand this anatomic position. This is the membranous septum, and this is the interventricular membranous septum. Please note that this is the aortic root, and this is variable. This position is variable. And here you can see in this beautiful drawing published in JACC, And you can see the different approach to this area of the AB block. This is important that the site of AB block in this patient is mainly infranodal. Therefore, you can see here the aorta protruding. This is the supraventricular crest. This is the area of his bundle. This is the area of the membranous septum, and this is the area of the left ventricular outflow tract. On the right, you can see the position of the lead in the his bundle regions in relationship with the position of the transaortic valve device. And this is crucial. How is the variability of this membranous septum? Please note on the right, by transillumination, the penetrating AB bundle and the subendocardial left bundle branch. How is the arrangement in the left side? How are the anatomic determinants in the left side? Also, variability, how it's the penetrating AB bundle. You can see the short distance just in the crest. This is right and this is left. But look here, this is inferior, the left bundle, to the membranous septum. Therefore, it's not only how is the length and the depth of the membranous septum, but also how the left bundle branch arise in relation with this membranous septum. The result of this is that we need to take into account how is the anatomy of the left bundle branch in relation with the subaortic outflow tract. Here you can see that the left bundle branch arises from the branches portions, and the red bundle branch appear as the continuation of the bundle of here after the left bundle branch has given off. Here you can see this is the left bundle branch penetrating his bundle, and the left is like perpendicular. And this anatomy also is important. When we analyze the left bundle branch and the interventricular septum, please note that the main common left bundle branch is also variable, as maybe from 1 to 14 millimeters the origin, and extend inferiorly toward the apex between 10 to 15 millimeters. Here you can see the left bundle branch, the intramyocardially located right bundle branch, and please note on the right in these dissections, the superior, the septal, and the inferior. The septal branch is variable, and the septal branch is also crucial to understand. When we analyze the three subdivisions of the left bundle branch, usually the superior division is usually thinner, horizontal, and the length is close in between the dome and the right coronary cuff of the aortic root. And we have the septal, and the variability like a fingerprint is in the septal branch. And we have the inferior, that is go to the inferior papillary muscle. The variability of the branches can be seen here. It was one of the main studies by James, published in 1976, that show a large individual variations in the subendocardial network. Many studies show the variability, and this is an important study by de Molin and Culbertus in 1973 that show where you can see the more important variability. That is the septal branch. Septal branch that may appear from the left bundle, from the left bundle, from the anterior, from the posterior, or may interconnect like a network in the so-called type 3. Therefore, when we try to see how the transaortic valve device affect the area of the subaortic outflow tract, we need also to understand not only how is the membranous septum, how is the variable membranous septum in the aortic root, but also how is the variable subdivisions of the left bundle branch. We now understand that we have three subdivisions. You know, in many reports that they are using two subdivisions, but we have clear that we have the anterior, the septal, and the inferior subdivision. Please note this study that we published just to analyze how is the aortic root in relation with the membranous septum. Look, you don't need to see the histology, just to see the transilluminations. This is right, this is none, this is right, this is none, this is right, none. Look, how is the distance, how is the position. Therefore, how is the penetrating AV bundle? Penetrating AV bundle means injury. Penetrating AV bundle means that if the device is there, you increase the injury. Therefore, variable position of the penetrating AV bundle, because the membranous septum is not the left bundle branch. Many people understand that the left membranous septum, left bundle branch. No. We have the compact AV node, we have the penetrating AV bundle, the area of the interventricular membranous septum is there, and we have the left bundle branch close to the right aortic cusp. And here you can see the distance, 3.3 millimeters. Therefore, the risk of induced AV bundle injury when we are there increase. Even because with the aging, we have changes in the rotation of the aorta. And these changes in the rotation of the aorta also imply variability, inter-individual variability. Here you can see the three subdivisions. This is the superior. This is the more reproducible subdivision of the left bundle branch, horizontal, thinner, through the right and none. And you have the variable septal and the inferior. Please note here the distance. In this, on the right, you can see the superior fascicle, and this is the right coronary leaflet, the distance. This is in the leaflet. Therefore, you are going to introduce a device there, and the left superior is in the leaflet. Therefore, the risk there increase. Now, this is, look please, this, we published this with Robert Anderson, and this is now our understanding of how is the arrangement of the compact AV node and the left bundle branch. Look, this is the mitral-aortic continuity. Here we have the left fibrous trigon. This is the right fibrous trigon. And the AV node, the compact AV node, try to identify that the compact AV node is in the area of the right fibrous trigon, and the penetrating AV bundle. The penetrating AV bundle, membranous septum. Some people study CT scan by identify the membranous septum and say, there is the his. No, there is the penetrating AV bundle, not the left bundle branch. The left bundle branch appear just very close here to the right coronary cusp. Here you can see, this is the main trunk. Therefore, the left bundle branch is in close anatomic relation with the right coronary cusp. Here, I try to simulate using the right-aided approach in the area of the left ventricle. You can see the area of supraventricular crest, the orifice of the coronary sinus, the vestibule of the tricuspid valve, and this is the left ventricular outflow tract, and you can see the pulmonary valve. Here, this is because we have removed the endocardium. You can see the arrangement of the endocardial myofibers, and you can see there, this is pulmonary valve, and this is here, you can see, no, this is not working. Yes, here you can see that the septal papillary muscle, medial, we introduce, and where are we in the left side? Therefore, look all the holes. You can try to do this in many times. Variable positions in the left side. You can do that in many hearts, variable positions. Therefore, you can go from the right to the left because the orientation of the right ventricular outflow tract, the orientation of the left ventricular outflow tract, the rotation of the aorta, the position of the membranous septum, the variable penetrating AV bundle create inter-individual variability. And this is very important because you can see on the right, this has been provided by our friend, Oscar Cano, different position in relation with the transaortic valve implantation for left bundle band patients. This is the left bundle band regions, more distally, more proximally. because this is the variability in this case. Therefore, taking into account in our mind how is the variability of this subdivision, how is the variability of the main trunk, and how is the area of the his bundle, therefore, and if we have the position of the distal his bundle, the area of the AB block, probably we are going to see that the left bundle branch patients increase our success during patients in this area. Thank you very much.
For this brilliant presentation, anatomy lesson. The last talk of this session will be given by the Dr. Bruno García from the Vall d'Hebron Hospital in Barcelona, and it's titled Conduction Disturbance After TBR. May they affect the outcome, the role of physiological pacing.
Bueno, buenos días, good morning. I'm Bruno García from Barcelona, from Vall d'Hebron, and I'm in interventional cardiology, so I don't know anything about anatomy, as the Dr. Cabrera shows very well, and I don't know nothing about electrophysiology, but I try to do my best with interventional cardiology, which is also a very nice specialty. I will talk to you, but I will start first saying that it was impressive. It was quite striking to see anatomy. I think nature is variable, as you say, but you know, if we face with variability, we need to be scientific, we need to be practical, and we need, you know, practical issues, and that's what clinicians or interventional cardiologists, we try to be more simple than the big variability of... Just 1 second. Gracias. Okay, let's go. I will not talk. You see that my title is Conduction Disturbances After TAVR, and I won't speak, you know, transcatheter aortic valve implantation. From now on, I will say TAVR. From now on, I will say not left bundle branch block, but LBB. From now on, I will say BAV and right bundle branch block, RBB. I think that everybody can understand that. I want to stress about what Dr. Cabrera showed us, that the injury of a TAVR into the outflow tract can be devastating for the conduction system. But I will show to you, this is our colleague Raul Moreno, who showed us in the first TAVR that we had conduction disturbances, and luckily the patient did not well. We could see that the mechanism of the injury was compression, hemorrhage, ischemic injury, and also inflammation. And in fact, this is, you know, from the anatomical point of view, but as I said, we want to be practical. What's that? Is this a big problem in our regular activity? Yes, it is, because as you can see here in the slide, we have, you know, in blue, I have marked in blue, we have the balloon expandable TAVR devices, and the, you know, in the bars in yellow, we have the percentage of AV block, complete AV block, and in blue, the percentage of new onset LBB. So this is really an issue, because as you can see, even with the best TAVR doing well for the conduction disturbances, we are ranging from 5 to 15% AV block, and new LBB from 20 to 40 or even more new LBB. So that means that it's a big problem, it's a big issue. In fact, nowadays, for the TAVR and for the interventional cardiologists, we could say it's our Achilles heel. I mean, we can implant TAVR in a lot of scenarios, but we know that we will end up in some patients, in more than 10% of the patients with a pacemaker. And does it has any clinical impact? Yes, you know that pacemaker implant, even if it's performed by very experienced electrophysiologists or cardiac surgeons, I don't care about that, but we have impact. We have clinical impact. It's not huge, and we can minimize it for sure, but there is a clinical impact. Not only economic impact, but also clinical impact. From the point of view of mortality, it has been quite struggling to find that even the need of pacemaker after TAVR has clinical impact in mortality. And as you can see, we needed a big meta-analysis of more than 40,000 patients to reach significance in mortality. That means that there is a protective effect of pacemaker, for sure. And in fact, if we analyze not global death, but cardiovascular death, there is no difference. So probably the pacemaker is protecting some issues, some events after TAVR, for sure. But for sure, there is also any other thing. And let me show to you what has happened in the last years with pacemaker implantation. As you can see in blue, the line in blue is pacemaker implantation during hospitalization after TAVR. And the yellow one is pacemaker implantation after discharge. As you can see in the very beginning, we were implanting a lot of pacemakers during hospitalization. We were quite afraid of what could happen with the patient. But afterwards, we learned how to predict some of these pacemaker needs, and then we avoided, and we had to implant some of these pacemakers after discharge. So, lines have crossed, and probably will cross even more. As I was saying, we try to be practical, and Dr. Cabrera showed very well some of the predictors, but there are a big spectrum of predictors for AV block during the TAVR implantation. I will just show to you some of them. One is, of course, this is a mechanical injury. So if we use TAVR with some overstretching, some oversizing, we have more pacemaker need. Also, as Dr. Cabrera said before, if we use self-expandable valves, and some of them like core valve, we have more percentage of AV block. Other predictors are anatomical, and we can avoid, as he pointed very well, that if we implant the TAVR a little bit higher, or as high as we can, being, let's say, successfully and safe, we can avoid and we can reduce this number. Also, the localization of calcifications under the cusps and in the LVOT are predictors of this need of pacemaker, so AV block. But probably that what we have and what is very practical is the EKG. So it's a little bit sad that even in interventional cardiology has been speaking, in the 21st century of EKG. But yeah, EKG is still available, is still very, very useful. And the first predictor of AV block is RBB. RBB is not only a predictor of AV block during TAVR, but also of other clinical issues, even in myocardial infarction, LV dysfunction. So RBB has been always quite important. And you see, in this study of OFRED, we were very astonished that the worst group was, in fact, the group with RBB previous to the TAVR and who after TAVR did not need the pacemaker. In fact, the pacemaker protected that group. So if the patient arrived with the RBB after TAVR, had AV block, and he was implanted a pacemaker, this had better outcome than the one who avoided the pacemaker. So be careful about the RBB and TAVR. In fact, in the guidelines, sorry that it's in Spanish, but I think most of our colleagues that speak other languages will understand that it's an indication 2A. If a patient arrives with RBB and in our cath lab, we implant a TAVR, and there is any changes in conduction, even the smallest one, then we should think about implanting a pacemaker. So we have to be very aggressive with RBB. In fact, as you can see, sometimes you know that in medicine, when we have a lot of factors, we can put, or we can try to have some scores, and to some of the scores plus. We could show that we can predict events quite easily. But this is not so easy in our field. And probably because, as Dr. Cabrera showed very well, because there is a big variability. So the big variability and the anatomical variability applies also to the prediction of some of these scores. But in fact, for example, in the one who is on the right, you see that apart from the history of syncope, this RBB, as we were saying, the width of the QRS, and also the valve oversizing. So some of the scores avoid some of the very important features, so it's not so easy to have scores. And now let's talk, in my second half, let's say, of my talk, about LBB, sorry. You know, as I said before, the impact of LBB is quite high. You see in the bars in yellow that with the self-expandable valve, we can reach even more than 60% of new onset LBB. That's the patients that arrive at our cath lab without LBB, but after the TAVR, they have LBB and it persists. So it's quite high. And it will depend, of course, as you see in the injury there in the anatomical part of the outflow tract. And as we were commenting with the Newton pacemaker, LBB has no impact, in fact, in mortality after TAVR, or at least we haven't found it. That's different, because there is a big variability also with the studies with LBB. And some of them have found that let's say the new onset LBB has impact on mortality, but some of them have failed. And even some of them are from the same author, and the same patients. So that will depend on what? That will depend on the period that we analyze. The longest the period we analyze, the more significant is that the LBB has some impact on mortality. And that we have to take that in mind, because probably the LBB has its effect, not immediately, but after some years. This is a slide just to show that big discrepancy from the studies, but this is due probably of the big variability between studies. And what we know, and I think this is quite reliable, this is just one of the studies, but most of them show the same feature, is that the ejection fraction with the new onset LBB declines. So it will go worse than if we don't have a left bundle branch block. And in fact, this affects not only the patients with regular function, but also the patients with impaired ejection fraction. And in fact, as you see in the diagram on the left, you know, this is in fact the ejection fraction with LBB, it increases, but it does not reach the increase that has with a patient that does not have the conduction disturbance. Also, we have some studies that, you know, they study more not only the ejection fraction but also the synchrony, and they have seen that if it's transient, if it's just during the implantation or just some hours after, this will recover. But if it stays, if the LBB stays, the desynchrony and the ejection fraction will stay and probably will not recover. So what do the guidelines say? In fact, they say that we just need to monitorize. This is something that you know, the guidelines, when they say that, and this is due probably from a study that I will show to you afterwards, and because we don't know a lot what will happen. So it's, let's say, a quite passive activity, so just monitorize it. It's like a standby position. I think this is the editorial that I like the most, talking about LBB after TAVR, and it's from a group I think from the States, but I don't remember if it's Cleveland or because Ron Workman was very active also with the TAVR. And what do they say? They say, you know, consider the left, even with broad QRS and heart failure, consider even resynchronization just from the beginning after TAVR. So this is after TAVR. Huh? So they don't expect gain in ejection fraction, despite they have, let's say, treated the aortic stenosis. And what do they say about persisting left bundle branch block? Consider electrophysiological study or continuous remote monitoring. I will talk just 2 slides about that. One is why do they recommend monitoring? Because this is a study from Josep Rodés that we participated in also. And what we were astonished is that when we have a patient with LBB and we continue monitoring him from, let's say, 3 months, in fact, the events of conduction disturbances probably they appear in the first 3 days. After these 3 days, most of the events don't appear. And what we were discovering in this study is that most of the events were not bradyarrhythmias, were not conduction disturbances. Most of the events were atrial fibrillation. You know that TAVR patients are very old patients with a lot of risk of atrial fibrillation. And in fact, atrial fibrillation happened more often with the balloon expandable valve than with the self-expandable valve. That was an issue that we found there. Let's talk a little bit about what can we do actively to choose which left bundle branch block is dangerous, let's say. The group that performed, the group of Rogers, the same group of Ron Wadsman, did something that I think is very interesting. Is just after TAVR to do an EP, an electrophysiological study, quite easy for you for sure, which is to measure the his ventricle period. And they put a cutoff, I think, quite high of more than 100 milliseconds to discriminate. If it's over 100, then we pacemaker, we put the pacemaker. If not, we stay like that, just with monitoring. Which is the only thing that I can tell you about this study is, okay, they choose and they found 4 groups, depending on if they had LBB and they need the pacemaker. But the only thing, as you can see in the bars, you know, the one that goes down is pacemaker implantation, and it comes from, I think, more than 30 or 35% of incidence, which is quite high. And the lower curve is the EP, the number of EPs that they've done by a percentage by patient. So as they increase EP, they avoid some pacemaker implantation. They put about 70%. I don't know, you know, that the statistical management sometimes is quite tricky. I think it's not that, but they avoid some of this pacemaker. At least they have, you know, they have an idea, they have a number, and let's try. This could be one of the ways to discriminate which are the LBB that need pacemaker. The other one is also quite interesting. You know that when we perform TAVR, we use sometimes a pacemaker lead on the left ventricle and the apex. And when we finish the TAVR, what we can do is we're retrieving this lead, we put it in the right atrium, and we can perform a progressive pacing, from, you know, with increasing frequency. And they put a cutoff of 120. It could be 130. If they find that they find a Wenckebach phenomenon, they think that this is a risky patient. If they don't find it, then it's not a risky patient. It does not need pacemaker. The only thing that I can tell you from the Wenckebach point is that it has a very high negative predictive value. So if the patient does not suffer Wenckebach phenomenon, this patient probably won't need a pacemaker with a lot of probability. And the last slides, I have to be honest, I'm not an expert on electrophysiology, so I just will show you what I found some months ago when I did the review. These were the first tests of his pacing. I think that it's a very smart idea, his pacing, especially in TAVI patients. But we know that we will find, or you will find, when we try to pace this zone, that there is an injury there. So I don't know if it's so easy to do it. And in fact, I just will show you that with this sort of pacing, that you are the experts, they found that they can narrow the QRS, and also that they have 2 zones, and I think it's the same picture that Dr. Cabrera showed us. Depending, the higher zone is probably the most injury, so it's probably the most difficult to pace, and the lower zone is probably easier to find it and to sense it and to pace. And from the point of view of electrical success, I know that it's successful. I don't know if that will be successful to avoid the impairment of ejection fraction with the time being, I mean, with the follow-up of these patients. But at least I think it's a very nice idea. And as a mode of conclusions, I will say that pacemaker need an implant is related to worse prognosis, but especially with global death, not cardiovascular death. We know now many predictors. Some are very strong. Some of them are very strong and very easy to know, like RBB block, but the scores are not yet ready. LBB is not the strongest predictor for pacemaker, but it's linked to worse evolution of ejection fraction over years. I think that decision algorithms that we have now on our cath labs are still very low and complex. So I think we are not in a good position now. So I think we need rapid strategies to decide which patients do we need to pace, even with left bundle branch block, or to treat, and especially with the modality that you are discussing these very nice days here, which is his pacing. Thank you very much, and especially thank you to Pablo and Antonio.
Thank you, Dr. Bruno García. So I think that the discussion could be in Spanish or English, as you wish. Any question in the audience?
Good morning to everybody. My name is Karol Curila, and I would like to ask Dr. Cabrera. I would like to thank him for his very nice educative presentation. My question is related to the anatomy of left bundle fascicles and the septum. So we know that the septum has its thickness, and at LV subendocardium, there is a layer where the left bundle branch runs, and this layer consists of the fibrotic tissue and fatty tissue, and then there is the LV endocardium. My question is, what is the thickness of this layer, and if this layer is constant, is it present all over the LV endocardium, or there are areas where this layer is thinner or thicker?
Thank you for your question. I have not shown the histological section from transmural point of view of the left bundle, because as I have shown just how is the extensions from subendocardial view from the so-called three subdivisions, three fascicles. In fact, when you perform transmural sections, there are also a variability between the number of layers. You can see between 3 to 15 layers of the area that correspond to these subdivisions. And in between the layers, there's also a variability of connective tissue. Sometimes you can find a very important presence of fibrous tissue. You can see 2 layers, one thicker fibrous tissue, 3 layers, small tissue, and subendocardium, okay? And this is superior. You have the muscular interventricular septum. Therefore, this is a very important also anatomy, because you can be there and you don't need to be just in the layers. You can be close in the connective tissue that this is very close to this layer, or no fibrous tissue, also adipose tissue in this some small artery there. No? This is, we have in one JACC case report, we have several pictures of this dissection, beautiful dissection that show the non-selective pacing. Why you don't need to be just capturing just in this layer, the left ventricle of the left bundle branch, because this is variable. How is the difference between the septal superior and inferior is also important, because it's not the same in the main trunk that you have a more number of layers than more distally. If you are in the septal area, or even in the superior, you have thicker component of the number of left bundle branch layers. Distally, less. But also, it depends if you are younger or older. and the number of fibrofatty tissue in between the layers. Because younger people, the layer thicker than the older people. Because the fibrofatty tissue interpose in this layer. Okay, therefore, I think it's very important also to understand how is the transmural component of the left bundle branch subdivision in terms of layer, connective tissue, fibrofatty tissue, and adipose tissue, and vascular component.
Okay, thank you very much. It looks like nature made it quite difficult because it's very variable.
This is a fingerprint.
Okay.
This is a fingerprint for any heart, and fingerprint with the variable with the aging. We born with the fingerprint, but we die also with our own fingerprint with the variability with the aging.
Thank you.
My question is for Dr. Bruno García. What do you think about a practice not very extended, that is the implantation of a pacemaker preventive before the TAVI implant? Do you make sometimes?
No, we don't perform it never, but in fact, in the guidelines, I didn't show it to you because for a matter of time, but in the guidelines, it's it's 3, so it's avoid it because sometimes you have more complications because of the pacemaker than from the TAVR. I guess you ask because, let's say, RBB with a high risk of calcium or whatever.
Of course, in not all patients, but in some patients with a very, very high probability.
And I think that the explanation is from the expert on my left because of variability. So despite you have, let's say, a red bundle branch block and with a patient that you will need to overstretch, let's say, let's put a patient, pure aortic regurgitation. We are now performing TAVR in these patients, and we overstretch more than 20% the annulus. Despite that, even with RBB, we don't know, we are not sure that we will need a pacemaker. So I think it is better to avoid and to implant it afterwards.
Wait.
Yeah. The only thing is, and I know that happens nowadays, is that some groups, they put the pacemaker to avoid the rate of new pacemaker on their series. And I think that's not fair. We have to be fair with our practice.
Okay, thanks very much.
Hello, fantastic presentation. I have 2 questions. One for the TAVI and one for... First of all, when we are talking about left bundle branch block after TAVI and prognostics, there are different prognosis messages. But is taking into account the presence of mitral insufficiency, because we learn about AV node ablation, we perform AV node ablation and we generate the synchrony in patients with moderate mitral insufficiency, maybe the patients get worse. I don't know if there is an analysis about that.
Very good question. No, to be honest, I know that, for example, that when we implant a TAVR and we have concomitant mitral regurgitation, we know for sure, and this has been described by our colleague Luis Nombela, that the grade of mitral regurgitation lowers 1 grade at least. So, and which is from the physiological point of view, is logical, because the post-load charge of our ventricle will improve. But I don't know from the point of view of the conduction disturbances. I don't know, and I don't know if this has been analyzed. Very good question. I don't have the answer. Sorry.
Another question is about patients with normal ejection fraction. What we think about patients with ejection fraction between 40 and 50. How many? Because we are more aggressive in these patients, and when we have a patient with ejection fraction 45, we try to implant previously like a CRT because we want to avoid abrasions to CRT, or we go directly to coronary system pacing.
Yeah, I agree. Well, in the state trial, most of the patients had a normal ejection fraction, and the average is 60. Just maybe 3 or 4 patients were in that range. So I cannot tell about those patients specifically, but in my mind, to lower the specificity of your pacing and accept the left septal pacing would be just for patients with a normal ejection fraction. And until there is some more evidence, I would go probably for a left bundle pacing with criteria, or maybe CRT if I cannot get it.
Thank you.
Good morning. Congratulations for the presentation. I think it has been great. I have a question that we sometimes discuss, Pablo and us, talking about patients with LVB. As we are right now in an audience with a lot of experts in electrophysiology, what do you think about measuring the HV after LVB in a TAV implantation? Do you use it? Do you believe in that? Do you think it's a good test to know if we have to implant a pacemaker?
Yeah, this is difficult. We still don't have the answer. And in fact, there are many groups. They are using different numbers for the HV. Some of the groups are measuring it just after. In fact, if you read very well the guidelines, the bad news is that they say that you have to do it 72 hours after the TAVR. And this is probably also logical because of the edema or the mechanical impact, acute mechanical impact. So I think let's say for the fast and active strategy is not yet demonstrated that is feasible. I mean, it's feasible, but it's not linked to conduction disturbance in the follow-up. But for sure, I think we have to do something. I don't know if the Benkeback period, or the Benkeback point, or the HV. I think that the group that I showed, the group of Rogers, they put the 100 because specifically from this phenomenon. If you have 100 with procainamide, I think that means that if it's more than 100, it's very probable that you need the pacemaker. So, to stress a little bit, but there are no still a concrete answer about that. There are groups that are performing it and groups that we don't do it, so we do well, let's say.
What about the electrophysiologists? Are you using your cath lab?
No, in our cath lab. In my opinion, to predict this AV bundle injury will be coming from the industry or from the device. I am not sure if will be depending on our electrophysiological study. You have seen what is happening with the device. I think new device will imply a lower injury of the conduction system, is in my opinion. You know what is happening with our heart. You know this will be always along the life. Then we need a different device. I am going to ask a question for a conduction system patient in those cases that what is now happening that now we implant a lot now, but we indicate tricuspid valve, percutaneous tricuspid valve interventions. What about how will be the implication of the position of the lead during conduction system that is different of the lead for right ventricular apex in terms of in the future for those patients that will need this treatment? I am sure that it probably, I don't know if this will be sure in the future variable.
Yeah,
what do you think?
Yeah. I don't know. I think that this is, I mean, we are the one who performed the tricuspid interventions, And when there is a lead, for sure it's more complex, and we need to avoid. In fact, we have.
I mean coronary conduction system lead, no right ventricular upper. Because
Okay.
The position is different.
But it's higher, you mean?
Higher.
Higher, but it crosses the tricuspid valve.
Correct.
So it will provoke probably different tricuspid regurgitation from the one that we know, because we don't find, at least I haven't found any patient with this sort.
What do you think, Pablo?
In the European Patient Symposium last year, I had to review this issue about tricuspid valve regurgitation in cases of spacing, and to my surprise, it seems that in most of the cases the mechanism is functional, because even in leadless pacemaker, the rate of tricuspid regurgitation is still very high. There are not many data about different position of leads, but to my surprise, in cases of his bundle pacing, there is no increase in tricuspid regurgitation, and as you know, we studied the position of his bundle pacing in our patients, and half of them are over the valve, and half of them are below the valve. So probably the anatomical position of the his bundle pacing do not affect the tricuspid regurgitation. But to my surprise, in a small study comparing different positions of the leads, the left bundle branch pacing was the position that increased much more the tricuspid regurgitation, probably because of functional mechanism. I don't know, but this is what is published in the literature.
I'm sorry.
Yes, there are some data that the left bundle branch area pacing, if the lead is implanted less than, in one paper 16, in the other paper 19 millimeters, and in the third paper less than 22 millimeters away from tricuspid valve, it increases the risk of tricuspid regurgitation. So if you are implanting left bundle branch area pacing lead, let's say if you are taking care about tricuspid regurgitation, you should stay at least 2 centimeters away from the tricuspid valve. But in that situation, you are not going to be very likely pacing distal trunk, but maybe proximal fascicles.
And probably will affect the septal leaflet of the tricuspid, no? Yes. Probably is the one who will be more affected. Interesting.
I don't have much experience in those cases, but in a couple of cases in our hospital, we have solved it with a CS pacing. So putting the lead in the CS in terms of mechanical, it's not affected. I don't know if functionally it's better or not, but that's a solution.
Bruno, nice talk as usual. You've been doing many TAVIs for long years, right? You do now more than 200 TAVIs. You know this complicates a lot the handling of the patient after the procedure. And from the clinician point of view, not the electrophysiologist or the interventional cardiologist as we are, and now that you are leading this study, fast track, about trying and simplify the management after. What are you doing? Because you have reviewed all the data, but you haven't tell us what you do. So what are you doing, and what would you recommend to do with LBB, which is probably the most messy thing that you may have, because if you have a block, you go for a pacemaker and that's it. But we need something, because in the guidelines it says 24 hours observation, and then some people go for HV measurements, some other don't. What would you do from your point of view?
Yeah, my regular practice, you mean, Pepe? Okay. Yeah, of course. I agree, and in fact, I will tell you some clues. One is, if LBB appears with the guide wire crossing, this will be probably a very, very aggressive LBB. So because it's with the less injury that you provoke, just the guide wire, not of the TAVR. So in these cases, we keep the monitoring of the reveal. If the LBB stays, is persistent. If it recovers during the hospitalization, we do the fast track. We don't. I mean, if it recovers immediately, for sure. But if it recovers during hospitalization, that can be 1 day. then the patient is, and we have a 1 week control in the outpatient clinic for all the patients, in fact, for all the fast-track patients, but that involves that. Apart from that, I think that we will, that will be a proposal for you, that we need something, as I was saying, something to test this LVB, like his period, his ventricle period. But from now on is the only thing I can tell you. So we still are monitoring a lot of patients with reveal, to be honest.
I have a question related to that. With left bundle branch block after TAVR, we have two main problems. That is the risk of AV block in the follow-up. That is very difficult to predict. And the second one is the risk of heart failure due to desynchrony. So with the conduction system pacing, we could treat both conditions. It's time to, what do you think about the possibility of pace all these patients?
Okay, so you mean in a preventive manner?
Yes.
For the ejection fraction?
Mm-hmm.
Yeah, good. I think, I mean, there are no data. It's just a thing. I think that we have, with the LVB, I think that we, and LV dysfunction, we need to be a little bit more aggressive than we have been these last years. Because we have some cases of patients that, in fact, we thought it was because of coronary problems, and it was because of the LVB. And the LVB, they drove from a normal ejection fraction to ejection fraction under 30 in less than 2 years. Patients that were okay from the other conditions. So I think that could be one of the reasons to be more aggressive with LVB, like with the RVB, you mean? Yeah, I agree, but I don't have, sorry about, no more data about that. Yeah.
I have one question.
We need to randomize, if so, that's the only thing.
I have one question for Dr. Valles. In the style trial, the 25-30% reached the septal pacing or left ventricular septal pacing. In this patient, the left ventricular ejection fraction remains stable at the end of the procedure, or in subgroup analysis, or?
So there is no subgroup analysis because it was only 70 patients,
yeah.
and it reached a statistically significant difference, but we don't have the analysis separated subgroups. I get that's what we aim to do in the state to trial with more patients. Yeah.
Okay, we think we have to move to the next session. Thank you very much to all the speakers.
Let's go. Good morning. First of all, we are going to start the session. I want to thank to Pablo and all the Huelva's team because the invitation to this conference, because you are the pioneers of the conduction system pacing. So it's for me a pleasure to moderate this session. We are going to start with 3 speakers, world leaders, speakers in the coronarius, in the conduction system pacing. So we are going to start, we have a delay. So we can start with Karol Curila from Czech Republic. So can start.
Hello, thank you. Good morning. It's my honor to be here in the place where conduction system pacing was. It should be okay. Okay. So once again, good morning. I am honored to be here in the place where the conduction system pacing was born. It's already 25 years. I would like to thank Pablo inviting me here, and it's really a pleasure to be here. I'm going to speak about the desynchrony assessment and in the era of conduction system pacing. So these are my conflicts of interest related to the presentation. So, you know, now we are doing conduction system pacing because we are saying it's better than standard right ventricular pacing. And if you want to understand why it's better, we have to go back to the roots. It's better just because we are saying it preserves ventricular desynchrony, which is in fact the main guilty for the bad clinical outcome in patients with right ventricular pacing. Then the question is, if the ventricular desynchrony is so important, how do we assess ventricular desynchrony and how we should do that to have the best outcome of our patients? This is a very nice paper which was published by Nguyen in 2019, that summarized the methods of desynchrony assessment during the pacing and during the spontaneous rhythm. Unfortunately, I have to say that the method which is being used the most in clinical practice, how to assess ventricular desynchrony, is still low-frequency standard 12-lead ECG. We have learned how to assess ventricular desynchrony during the spontaneous rhythm and pace rhythms, and the spontaneous rhythms, it's quite easy. We look at the QRS duration. If it's below 110 milliseconds, we are saying it's good, it's physiological because it's narrow. If it's longer than 110 milliseconds, we are looking in the V1. When there is the late R, it's right bundle branch block. You see it here. If there is no late R and the QRS is white, it's left bundle branch block. And that's quite okay, and we can agree that might work quite well. But does this imply it's so easy also during the pacing? If you look here, you see 3 paced QRS complexes. The one on the left has the shortest QRS duration. The one on the right has the longest QRS duration. So if my question to you would be, please tell me which type of pacing is the most physiological, then based on the QRS duration, you should say this one on the left is the best and this one on the right is the worst. But surprisingly, if I uncover what's paced here, you will see that the shortest QRS duration was with the right ventricular pacing. In the middle, we have left bundle branch area pacing, and on the right, with the longest QRS duration, with the worst ventricular desynchrony, we have biventricular pacing. So this type of pacing, which saves lives and reduce morbidity in patients with heart failure, should be based on the QRS duration, the worst of these 3, and the one we consider non-physiological should be the best. So maybe the QRS duration is not the perfect measure of ventricular desynchrony in patients that are receiving pacemakers. And we are using different methods of desynchrony assessment already for 6 years, and we have been one center which developed the method, and this method is called ultra-high frequency ECG. And during that time, we have learned a lot, and I am going to share at least a part of the knowledge I have gained during these years. Ultra-high frequency ECG is just the ECG. So it is using the standard V1 to V6 or V1 to V8 leads, and it displays desynchrony in very easy and fast way. So you see in this map that under the V1, you visualize the activation of the right ventricular lateral wall. Under the V4, V5, it is the apex of the heart, and V7, V8, it is LV lateral wall. In the patient with narrow QRS, all segments of the heart are being activated in the same moment. So this is physiological. This is normal ventricular activation. When you have right bundle branch block during spontaneous rhythm, you see it also from the low frequency ECG, but here with the ultra high frequency ECG, you see that the RV lateral wall is delayed, and you can quantify the delay. It is 70 milliseconds in this case. In left bundle branch block, in this case, the delay of the LV lateral wall is 107 milliseconds. So this is really a huge desynchrony where the LV lateral wall is being activated more than 100 milliseconds after the activation of the septum and the RV lateral wall. And not only this is the shape of the desynchrony, this map here is wider compared to narrow QRS and right bundle branch block. The reason why it's wider, because the conduction is slower. So there are 2 informations, the desynchrony and the speed of the conduction. So then, when we look back at the pace QRS complexes I have been able to show you before, now you will understand that the one with the narrowest QRS duration is not the best, because RV pacing induced a huge ventricular desynchrony here, where the septum and RV lateral wall was being activated 50 milliseconds ahead of the LV lateral wall. The one which now we are saying is one of the best methods of pacing, that is left bundle branch area pacing, had the QRS duration due to delayed activation of the RV lateral wall, but the septum, apex, and LV lateral wall are still being activated synchronously. And biventricular pacing also present with a quite nice ventricular desynchrony or synchrony, despite the QRS duration was quite wide. So that is the information we can obtain from the ultra-high frequency ECG. And the next question is, I hear it quite often, so are these only the nice figures, or they are relevant to any other measure of desynchrony? To answer this question, we have conducted the study where we measured the ventricular desynchrony during the spontaneous rhythm and pacing in patients with bradycardia and measured the mechanical desynchrony from the echo as the time delay between the opening times of the aortic and pulmonary valve. This is a well-known measure of interventricular mechanical desynchrony from the echo. And then we measured electrical interventricular desynchrony from the ultra-high-frequency ECG as the V1 to V7 distance. And the question was, is this distance from the ultra-high-frequency ECG similar to the time difference between the opening times of the aorta and pulmonary valve? I was quite lucky and happy to see that yes, it is, because you see here, looking at echo before pacing, interventricular mechanical desynchrony was 0 millisecond. After RV septal pacing, it was 25 milliseconds on average. From the ultra-high frequency ECG, the same values were seen. So the electrical desynchrony seen from ultra-high frequency ECG correlates very well with the mechanical desynchrony assessed by this way in echo, and the correlation coefficient you see here was quite high. So what we have been using this method for in the last years, we have been using to show that the QRS duration is really not the measure of desynchrony you should be using during the pacing. And the first quite relevant clinical question was if QRS duration should be used as a measure of desynchrony in patients with non-selective his-bundle pacing, because non-selective his-bundle pacing is the dominant type of myocardial of capture when you are doing his-bundle pacing. You are capturing his-bundle and myocytes that produce QRS duration, which is wider because there is a pseudo-delta wave. And the question was if this is the same as doing the selective his-bundle pacing, where the QRS duration was narrower and QRS complex was completely physiological. So we have compared the non-selective his-bundle pacing, you see here, to selective his-bundle pacing, you see here, and despite the QRS duration for the non-selective his-bundle pacing was wider, we have not been able to see any difference in level of ventricular desynchrony compared to selective his-bundle pacing and compared to the spontaneous rhythm, while myocardial pacing in the parahisian area significantly increased ventricular desynchrony. So since that time, we have been using non-selective his-bundle pacing as the method which was dominant in our lab because we wanted to have conducting system capture and myocardial capture, because in case you lose the capture of the his-bundle, you still have the safety backup pacing, that is myocardial pacing of the basal septum. We have very early understood that pacing the his-bundle proximally in the atrial or annular location is not a good job. You have to go more distal. We were trying to pace the his-bundle below the level of tricuspid valve. So we have been pacing distal his-bundle or proximal right bundle branch. And then the next question arises, is this the best method of pacing from all the other locations from the right ventricle? So what we did, during each implant procedure in 50 patients, I have paced distal his-bundle or proximal right bundle branch, and then with the atrial lead, I paced apex, septum, anterior, and lateral wall, and I looked at the level of ventricular desynchrony. So now maybe you are not surprised when you look at the red graph here that the non-selective his-bundle pacing or proximal right bundle branch pacing presented with the least left ventricular desynchrony. So this was the best method of pacing compared to all the others right ventricular pacing locations, because the ventricular desynchrony was 3 times smaller compared to pacing the septum and apex, and 5 times smaller compared to pacing anterior and lateral wall. But also interesting observation was that despite the QRS duration was different during pacing the apex and the septum, the left ventricular desynchrony was the same. So again, looking at QRS duration during the pacing the RV septum and apex doesn't tell you anything about the left ventricular desynchrony. And in fact, we know from the clinical studies, it doesn't tell you anything about the clinical outcome of the patients, because no clinical study showed benefit of RV septal pacing over apical pacing, despite all of them showed that the QRS duration was narrower. And maybe the answer is just ahead here, and you see it in front of you. Since 2019, and also thanks to Weijian Huang, who is here, who taught me, we have switched very early from his bundle pacing to left bundle branch pacing, and then very early to left bundle branch area pacing, because, you know, pacing the left bundle might be not so easy as it looked like. So from time to time, we are capturing the left septal myocytes. And the next relevant question came up: is the left septal pacing as good as left bundle branch pacing when the QRS duration is the same? When you compare the QRS duration during left septal and left bundle branch pacing, there is no difference. The QRS morphology is the same. You have the late R in the V1. The area is very similar, but for left bundle branch, you have to be more subendocardial, more proximal. For left septal, you have wider area. When we looked at the QRS duration, in the study we conducted in more than 60 patients, we have seen that the QRS duration for sure is the same during left septal and left bundle branch pacing. But when we looked at the level of ventricular desynchrony, we have seen that there is a difference between left septal and left bundle branch pacing. And the difference is, you see in front of you, is that left septal pacing presents with better ventricular synchrony. So the global ventricular synchrony with the left septal pacing is better compared to the left bundle branch pacing. When you go deeper and you capture left bundle branch, you will have better LV synchrony, because this is fast, this is narrower, so that means faster, however, at the cost of increased interventricular desynchrony. So when you are practically performing left bundle branch area pacing and you implant the lead from the right side of the septum to the left side of the septum, and you reach the first location where you see a tiny small R in the V1, so that is the left septal myocardial pacing in this study, you have perfectly balanced ventricular activation. RV lateral wall, apex, and LV lateral wall activates in the same moment, but the LV activation might be a little bit better. And if you go deeper by 2 to 3 millimeters and you capture left bundle branch, then you have perfect LV activation. But simultaneously, you increase left to right desynchrony, which we do not know is of any clinical significance. So practically, what is left septal pacing about? When you are pacing the right septum, the septum from the right side, as you see here, you are producing right to left interventricular desynchrony. In this case, it was 38 milliseconds. This is the same patient. In 5 minutes, we paced the left bundle branch here. So what's different here? Pacing from the left septum, you are producing left to right desynchrony. So two different desynchronies are produced pacing the right and left septum. So then the question is, what is in between? What's happening when you are penetrating through the septum? Because when in the right septum, you have right to left desynchrony, and at the left septum, left to right desynchrony. So somewhere in the middle, you should have the place where the ventricular desynchrony is the same, is minimal, and this is what's happening here. With the RV septal pacing, there is right to left desynchrony. Being deeper for 4 millimeters, you see that the level of ventricular desynchrony decreases. Then suddenly, usually at 60%, 70% of the septal thickness, you have perfectly balanced ventricular activation. When you go deeper, you increase left to right interventricular desynchrony, but simultaneously you little bit improve the activation of the left ventricle, so you increase left ventricular you improve left ventricular synchrony. Nowadays, already for a few years, we are not even more looking at patients with bradycardia, but we are looking at patients with heart failure and left bundle branch blocks, because we have a new era of the CRT, and you understand that, because when we had only biventricular pacing, it was quite good, because we could do bi-V pacing to improve the mortality and morbidity of the patients. But now, if the bi-V is suboptimal or fails, you can go for his bundle pacing or left bundle branch area pacing. But the problem with the his bundle pacing and left bundle branch area pacing is that it makes sense to perform them only in those patients who have the proximal block. So who have the block in the left bundle, and then you place the lead at the level of the block or behind the block, and you can overcome the block. But however, we know that 1/3 of patients which look on the ECG, they have the left bundle branch block. In fact, they do not have the block proximal in the trunk of the left bundle or the his bundle, but the block is distal. So in 1/3 of the patients, you might think that left bundle branch area pacing or his bundle pacing CRT is a good choice, but because the block is distal, doesn't make much sense to pace before the block, because you cannot correct the block. And now, the question is how to know in which patients the his bundle pacing or left bundle branch area pacing could be performed. So my question here would be to you, this is a CRT case from my lab, Patients with heart failure, ejection fraction 25, QRS duration 183 milliseconds. So is it left bundle branch block? For sure it is left bundle branch block because it's not right bundle branch block. The best we have, how to know if it's proximal or distal, it's Strauss left bundle branch block based on the data from Upadhyay study. So is it Strauss left bundle branch block? It is Strauss because there are notches in 1 and AVL. So it is Strauss left bundle branch block. But is this true proximal left bundle branch block? The answer is no, it's not, because it's intraventricular conduction delay. And the way how we know that, because we are mapping the left septum with the catheter, as you see here, and in this specific patient, you see there was a preserved activation of the Purkinje fibers at the LV septum, which excludes the possibility this is proximal left bundle branch block. And in fact, what we see already for many years is that the patients with IVCDs, as the first one here, differ in the activation on ultra-high-frequency ECG from the patients with true left bundle branch blocks. Those patients with true left bundle branch blocks, they have a huge interventricular desynchrony, that is V1 to V8 delay, as you see here. Many patients with IVCD, the interventricular desynchrony is quite small, and if there is desynchrony, this desynchrony is inside the left ventricle, as was in this patient with a scar after the transmural myocardial infarction, where there is a zone of slow conduction under the lead V4, V5, and V6, V7. So the patterns of activation in IVCD and true left bundle branch blocks are different on ultra-high-frequency ECG, as we have seen in the last years. The next very important question was, which method to perform as a CRT to have the best synchrony of the left ventricle and have the best LV work effectivity? Is it the BiV? Is it left bundle branch area pacing? So which is better? So for this, to know the answer, we have conducted a study where we did in 35 consecutive patients both, that is left bundle branch area pacing with left septal or left bundle branch pacing, in a few patients both, and also biventricular pacing. And we have measured ventricular desynchrony and LV work effectivity. And the results you see here, we have understood that both methods are perfect. So that is the BiV CRT and left bundle branch area pacing CRT. They both work very well because they significantly reduce ventricular desynchrony, as you see here, which translates into the increase of the blood pressure. So also LV work effectivity is perfect during the BiV and perfect during left bundle branch area pacing. When we looked at left septal pacing and left bundle branch pacing specifically against the biventricular pacing, we have seen that left septal pacing has the same level of left ventricular desynchrony as biventricular pacing, and also LV work effectivity was the same. Left bundle branch pacing was, on the other side, better. LV synchrony was better, and the LV work effectivity was better, but the gain of 4 millimeters of mercury was not so huge as we saw when we compared the BiV to the RV apicoseptal pacing. So in fact, this is quite good message, at least for me, because now you know that when you are doing CRT and you can do proper BiV, do it, because you will improve ventricular desynchrony. When you cannot do proper BiV CRT, go for left bundle branch area pacing CRT. If you can achieve left bundle branch capture, you did a perfect job. But when you achieved left septal myocardial pacing, you also did a good job, because you have the same level of ventricular synchrony and same LV work effectivity as you would see with biventricular pacing, which at least for me is a fantastic method, because it opens you the possibilities to improve the ventricular desynchrony and to improve the quality of the life and maybe mortality in your patients. The biggest advantage I see with the ultra-high-frequency ECG is easy to read, can be done in all patients, and the information is very fast. So you see here the patient with left bundle branch pacing, and the information collecting of the data started before 6 seconds, and you see that in less than 20 seconds, you see the resultant pattern of ventricular activation, which here is left to right delay with the RV lateral wall being delayed for 23 milliseconds compared to the LV lateral wall. So based on my knowledge and based on what I have seen in the last years, I have to say that I believe we have to move from the standard ECG and QRS duration measurement as a method of desynchrony assessment to something else. It may be ultra-high frequency ECG, it may be some different tool for desynchrony assessment. Because when you look at this picture, you will understand that the devices for the ECG change a little bit. We don't put the hands and feet of the patient to the water anymore, but the principle of the ECG is still the same. We are looking at the same curves, same signals, and those guys, they never intended that the ECG should be used as the marker for desynchrony assessment, and that is the reason we need to move for a different method, how to properly assess the ventricular desynchrony in patients that are paced. Thank you for your attention.
Thank you very much, Dr. Curila. You are invited to sit down with us. And the next speaker is Dr. Francesco Zanon from the Hospital de Rovigo, Italia. Speak about what is your first option in patient with indication for CRT.
Thank you very much. Good morning again for the second time here. It's again a pleasure. Again, thanks to Pablo to this invitation. So, Pablo, great. So these are my conflict of interest. And, well, so biventricular, or this, now we say biventricular, but for years it's been called CRT, that means cardiac resynchronization therapy. Now we include also the conduction system as a way to resynchronize the heart, because as wonderfully explain and show us Karol with these wonderful images, you can really resynchronize the heart also in other. So let's say biventricular. Biventricular is a class 1 indication, and so if we have a clear patient with depressed ejection fraction, left bundle, so is class 1, and more than 150 milliseconds is a clear indication. Because many randomized trials has demonstrated that increase survival, so reduce all-cause mortality and reduce especially heart failure hospitalization. So very hard endpoint. Also, the first time of the trial on CRT demonstrated on symptoms, so increase quality of life, increase the size capacity. And then the second part of all the trial on CRT demonstrated the hard endpoint of mortality and heart failure. And yeah, that's we already say. But is all clear? Is all wonderful? No, because for example, we know that there's no effect on right bundle. And it is true that if you go on all the randomized trial, the right bundle population was not so huge, usually 10, 15%, no more, but also the so-called intraventricular aspecific delay has no effect or a lower effect compared to left bundle. So at the end of the story, there are approximately, depends on which are the target, but about 30 up to 40% of people that not respond to resynchronization. And then also we can have some difficulty in managing our intervention. Why? Because now we have many tools, so it's much more easy to reach what the so-called target vein. But it's well known that sometimes there are tortuous vein, difficult to assess, some valve. Sometimes we have to do venoplasty, and if we have scarred the problem of the threshold, the problem of phrenic nerve, and so on, also lead stability. So due to all these things, and this is a clear example in which we did a lot of, also in our itinerary on cardiac pacing, we do a lot of also hemodynamic study on CRT, and we are looking with crazy idea that I had more than 10 years ago to go in each vein and measure the DPDT and the delay and so on. So in this case, for example, I don't know if it doesn't work, the mouse? No. Yes. So in this case, for example, there are very small vein, not viable, tortuous vein here, and at the end we find that we also go, well, here there is probably a middle way vein, but if you see the QLV in this, oh, it's curious because I can see the marker here, but not here. On the left part, you can see the QLV. QLV has been for many studies determined as a good predictor of resynchronization. What does QLV mean? It means a delay between the two parts of the heart, so septum and lateral wall. So if you measure the delay in the where you put the lead, and this delay, like in this case, 50 milliseconds is not a big delay. So if you pace there, means that probably you are not going to capture, so to resynchronize much of the heart. Usually, to have a good signal, you can have the electrical signal at the end, completely at the end of the QRS. That means that we are gaining and recruit all the delayed part. So in this case, for this, and after, as you can see here, procedural time, 2 hours and 25 minutes of fluoroscopy. So after checking all the vein, going and measure that, so we decide to go for this one. And after few attempts, probably the first attempt, we had, like in this case, a good fixation bit and a very nice correction of the QRS. But also, what happened in this case, this is a patient with a dilated cardiomyopathy, and here you can see the MRI in which, for those who are not familiar, also I'm not familiar, but some radiologists helped me. So look, so this is anterior, this is lateral, posterior, and this is septum. So where we are independently of measuring the QLV, but usually the target zone for CRT is the lateral wall, is it? So, and look here, all the lateral is scarred, it's completely scarred. So at the end, we go like this for his pacing, and we have a wonderful. So this is also included in the guidelines that if you don't reach, but in this case, after looking at the MRI, we decide to go directly for his. We obtain a very narrowing of the QRS, and then the patient, as you can see, the ejection fraction improve from 27 to more than 40%, and the patient is that for sure. Also, this patient is a colleague that came to me to be resynchronized. I show you this yesterday, but again, just to confirm what happened. So after pacing the his and after reducing the QRS duration, but also not only Karol, could show you how to resynchronize, but also this system is a wonderful system to understand what we are doing. Again, what is purple is what is activated very late, 200 milliseconds. What is the propagation? So the dot are the propagation which is slow, so activated late and slow. And this is in case of 180 milliseconds of this left bundle. What happened with his spacing is yellow, that means that it is more rapid, and the dot are at the same time, so that means that we correct completely. But it is so difficult. Well, it's not so difficult. Look, in this case, that's the first. Just look for some extra bit and then just paste it. That's it. If you compare to 25 minutes of fluoroscopy and to more than 2 hours of procedure, this is very simple method. So I don't want to end up and say this is my first option, but so those are some examples. But which are the clinical data? And so let's go through some study. Of course, we need to know, we need to have randomized. Do we have randomized? Unfortunately, not. This is the only one, and in which they compare, and the strong point is randomized. The weak point is few patients and not so strong endpoint, because the endpoint was only ejection fraction. In any case, I go through, and here you can see, so 20 patients per group, and also we can discuss the success rate, which was lowest with the BIV compared to, anyway, if we go to the result, so in both intention to treat and per protocol analysis, why we put also per protocol, because I don't remember who showed there was another randomized on his spacing, and in which there were few patients, was not significant in intention to treat, was significant in per protocol, which is not what we expected from a trial, because in a trial we do expect intention to treat, which is the first. So we put patient in to one treatment, we put patient in another treatment when we compare, and that's the real result of the. If we go, because of some crossover, to look which was, so that's per protocol, but it's not the true. Anyway, in this we obtain also that was superior, the left bundle, in terms of both increase ejection fraction, as you can see, but was better for, and this was small. Then there are some non-randomized, like this one, and the weak point will start with weak point, non-randomized. Strong point, the numerosity of patient. Look here. This is also, I think you were in Karol in this, in this multi-center, which were European and US center. And so the strong point, look, all the patients were almost 2,000. And another thing that is to be underscored, more than 1,000 with left bundle, okay? And the endpoint, strong, like made it CRT. So is heart failure, hospitalization, and mortality, combined endpoint. And if you look at the total of the global, or 1,800 approximately, So there was a significant improvement with LB compared to BIV. And the second endpoint, so if we divided the mortality and heart failure, but I want to underscore one thing. If you remember MADIT CRT, which was a milestone in terms of CRT, the combined endpoint was mortality and hospitalization. But when they divided in mortality was not any difference. The global was driven by the reduction in heart failure hospitalization. And if we compare only those group of patients with left bundle, which was very numerous, more than 1,000, look, the difference was even more significant because it was much better compared to the globality of the patient, was much better with the LB compared to BIV. And no difference in terms of mortality in this group of patients. And as expected, sub-analysis, as expected, is better for reduction QRS, but also there was better improvement in ejection fraction and also in near class. But again, the same, more or less the same centers, we also analyze the difference in terms of arrhythmic burden. And arrhythmic burden was divided in VT or burden of AF. And in both arrhythmic burden, there was superiority of left bundle compared to traditional BIV. Again, this study, weak point is non-randomized, to be honest. The strong point is multi-center, a lot of patients, more than 1,000, and also quite good follow-up. But is in every patient, we also analyze the same center and always with our friend Pugal like a leader in leading all the study. Also, we analyze the impact of left bundle in terms of mid-reduced ejection fraction. So this ejection fraction, which is in the gray zone of 35 to 50. And so look here, we start with, at the end of the story, more than 1,000 it was included. There was a little bit not balanced, okay, because approximately 200 biventricular, and the majority were conduction system in which the majority were left bundle, more than 600. But again, if we look for primary outcome, again, strong hard endpoint, death or heart failure hospitalization. And as you can see, in green is conduction system, 22 compared to 34, and the hazard ratio is less, is 36% difference. And this is the central illustration. As expected, as this is in line with the previous study, as expected, there is much more reduction in QRS duration. But also, if we analyze the primary outcome in all patients or in left bundle, again, in left bundle there is a better success rate. And again, if we divide it in heart failure hospitalization, is the best drive for the different, not so much different for all-cause mortality. Was it nice to see is that there is no difference at all. The lines are superimposed between his bundle and left bundle. But again, everybody now is one of the most famous. But it's just to say that it's not only a case or schematic, we say proximal or distal, but also we can have proximal, distal, and both. So we could have patients that have both, proximal and distal. And for this reason, we can mix up and do what is called the hot or lot CRT, in which we combine his and BIV or left bundle and BIV, and this is an example. And as I showed yesterday, we already did this 10 years before, and in which we collected, and as you can see, also this was presented in a European. Oh, thank you. Sorry. Was presented in European some years ago, but what is nice to see is that after a follow-up of 5 years, is clear the difference in echo between a clear remodeling between this one and this one. And I go to the final. So which is my favorite? I always say I just married my wife, and then I don't want to be fans of something. We have to know for our patient which is the best strategy. So to give the patient the best opportunity. So there is not only one. We have to be familiar with every kind of technology. We have to understand which is the main problem in this patient, which to try to go in this patient from a clinical point of view, from a physical pathological point of view, and then decide. Of course, at the center now, there is still for guidelines, BIV, but then we can combine in hot, in lot. There is also coming on what is all this new world of leadless, in which, especially for the wires, we can put this is very small wires on the left part, and so just spacing the left bundle, but also, of course, left bundle and his bundle pacing. And that's my conclusion. Thank you for your attention.
Let's go with the next presentation, Professor Huang.
Good morning, everyone. It's an honor to be here to share our experience with conduction system pacing. I find many people from Wenzhou live here. And we started his bundle pacing in 2011. First case is failed with BIV pacing. And the second very exciting case is non-respond. So both cases changed my idea. And so we start his bundle pacing for patients with left bundle blind block. And we found it have a better clinical outcome. A super response about 80% of patients, but we found we should increase output to correct left bundle block. Only 16% of patients with similar threshold for both his capture and correction left bundle. That means only very low percentage we can have a pacing near beyond the block. So why we have this phenomenon? Because his bundle anatomy, narrow target, and fibrous body, and affected by many cardiac disease, for example, infla Hissam block. So, in our center, we try to improve the technique, place the patient lead distal as we can. Usually, most of them, we place the patient at ventricular side. Then we have a reliable ventricular patient side for safety. And also, we try to screw deeper, have a better fixation. Then we have a long threshold, chronic stable long threshold for his bundle. And this result at different stage, we have a lower threshold after improved technique. But for some patients, very high threshold and the field, also we have improved his technique. So in 2015, we had a successful left bundle pacing for the first case, and it's very clear. This is true LVP capture because we have a selective LVP pacing with clear discrete between stimulum and left ventricular activation. And also we can optimize left ventricular activation to get best left ventricular activation and improve the interventricular ventricular synchrony. And also we have a clear evidence of the patient side beyond the block. This is a pace-induced cardiomyopathy. The patient have an AV block with a right bundle branch block pattern. From his bundle pacing lead, we found the patient to have a nodal block, infla his block, and from left bundle pacing, there is an intact conduction between left bundle to ventricular activation. So it's safety. And the journey left bundle started with addressing big doubts because we submitted the paper always be refused. But journal, Canadian Journal of Cardiology is very nice. They accept my paper. So we have a first case of left bundle pacing. So how to spread this technique? We should collect with the international colleague, define the criteria of left bundle capture, develop the acceptable procedure, etc. This is Pogo and Sharma and Tang and Karol here, yeah, and Kevin, and we need to visit our center. And in 2018, I visited USA Geisinger Center and helped them to perform 80 cases with left bundle pacing. And also we have a live demo show on APHRS and also in China from many centers, maybe more than 500 cases, doctors. Now, I talked about the definition and classification left bundle branch pacing. Yes, it's clear. True LV capture we call the left bundle branch pacing, and only local myocardial capture we called left ventricular septal pacing. But sometimes we are unable to confirm left bundle capture or no test performed. So left bundle area pacing, we confirmed left bundle pacing include left bundle branch pacing confirmed and left ventricular septum confirmed, unclassified left bundle area pacing. So this is a classification. And how to confirm? Yes, we use EP mapping to confirm it. So this is a gold criteria, but it's not a clinical practice. And we can use abrupt shortening, STLVT. That means transition morphology, transition sign, including abrupt change in morphology. For example, new onset R-wave pattern and selective L pacing and modified STLVT is very important because absolute LVT is not specific. So compare STLVT to native LVT, his bundle pacing LVT, and R-wave peak time. Then maybe we have a increase specific for diagnosis LVB capture. Here is V6 to V1 interpeak in patients with different sites. For only 20% patients have this sign with the interpeak more than 44 milliseconds, so very low sensitivity, affected by pacing site, whether there is a RBB block or left bundle block. And also, someone raised individualized R-wave peak time. Yes, it's very useful in narrow class comparison, but we should know also affected by pacing site. If the pacing site proximal and potential ventricular interval more than 30 milliseconds, then we have a false negative. And potential, especially with current, is very useful predictor. That means we have a low threshold, but it is not a direct sign for true LV capture. And this is criteria for LV capture. So, in our center, we just recording transition in patients in patient morphology. We can diagnose true LV capture just according to morphology change. Then we no definite measurement needed, and no measurement, no potential recorded. So it's very simple. We should simplify the criteria for LV capture. And also we should modify classification left bundle branch block in the center, just according to corrected by whether can be corrected by his bundle pacing, complete correction, partial correction, unable correction. And also we should know normal correct correction, correct method to correct left bundle by his bundle pacing. We shouldn't place the pacing lead at ventricular side. That means right bundle branch pacing. You cannot correct left bundle branch because potentially recorded very similar. How to differentiate? Just according to angiography or current of local myocardium. So it is very important. And also we should increase output to very high, not just 10 volt at 0.5 milliseconds. We should increase output to 10 volt at 1.5 milliseconds, then you have a good result. And how to perform left bundle? Initial site for left bundle is very much. We should precise, not rough, just according to fluoroscopy. It's very not good anatomy because very different. So mapping conduction system area or tricuspid valve angiography is good, is precise position. And also, during preservation, we always according to characteristic of patient morphology and aging. For example, if no current of injury of local myocardium, that means maybe scar, maybe chest valve. So, if potentially caught, that means right bundle branch where screwing maybe RBB injury occurred. Also, we should have a technique to record both two channel technique, one for LV potential, one for current injury, very, very important. And here is a case, for example, current injury, then just screwing. We found the amplitude current of injury increase, that is good sign. Or we have a premature beat. In this case, we screw the pacing lead very slowly to show the pacing morphology change, how the pace the morphology change. Sorry. Next page. And also we should differentiate whether his bundle pacing or right bundle pacing. Very important. At the early stage, high threshold for his bundle pacing, maybe many of them is the right bundle branch pacing. So it's very important. And this is a case, a live case, how to get best target, continuous observing to monitor LB potential. If the LB potential will curve, that's final target. Then we have a stable, very low threshold for LB capture. Also, we should observe amplitude of current of local myocardium injury. Next. And here is a case with LBB potential. In patients with left bundle branch block, continuum, then we have a premature. Then we found LB potential with current of injury. This is very important. So continuous observing is very important. And how to test? Sometimes we should change pacing rate, program paced, but less used because in our center, only less than 5% patients who need this method to differentiate LV septal pacing or true LV capture. And this is a case with septal perforation. So monitor the amplitude of current injury and the morphology is very important. And when continue or stop screwing the lead, this is the final target. In the center, now we have a 95% with this sign. And also, sometimes it's very hard to advance the pacing lead into the due to scar. If we turn back strongly, sometimes we should change the position. Or you can use electrical cut. And at the end, we should perform pacing lead stability before and after we should compare the LV potential and the morphology of paste. So this is very sensitive, not an instant threshold. And the technique we should reshaping and sheathing technique. For example, C315 in CS sheath, it will give us a strong support and to avoid right bundle branch injury and accurate position. Very, very useful. So in a sense, maybe I have more than 30% of patients with sheath technique. This is a live case. Not cut off the delivery sheath. RBB injury usually caused by pushing CS315 or pullback advance. So we just advance or pullback in the CS sheath, then pull back CS sheath. So CS delivery sheath could be helpful to reduce and also we should know true air have a better electrical synchrony, especially left ventricular synchrony. It's clear true have a shorter, a true LV capture have a shorter about 20 millisecond LVET compared to left ventricular septal pacing. And also we should know true LV capture for most patients will lead to shorter R wave peak time. But we have a difference in R wave peak time and the left ventricular peak time. So we should know this idea. And also we should how to compare the electrical synchrony in patients with left bundle blind fusion with native is important, then compare. This is a case, true LV capture and LV septal pacing, much different result. And this is some study showed true LV will have a better electrical synchrony and a better clinical outcome. Yes, good clinical outcome compared. And this is our center. There are 9 patients upgrade due to loss of true LV capture. Let's look at the result. After upgrade true LV capture, then cardiac function improved. And how to get a better electrical synchrony by left bundle pacing. This is many method, bipolar pacing, fusion with native, and with his bundle pacing. So we should know this one, but we don't know whether the result have a good clinical result. This is a case, different output use unipolar, bipolar, and fusion with native. We know selective LV pacing fused with native looks like best morphology. And this is a fusion case, fusion with RV pacing, then we have a very nice QRS complex. And this is a patient with AV node ablation and AF. So his bundle pacing plus left bundle pacing have a normal QRS complex. And yes, we use a lot of CRT and optimize pacing in IVC, but some papers showed a lot of CRT minimize RBP pattern. Why? I don't know. Because you just use additional CS pacing lead. And also, we should have a technique, proximal LB pacing and distal pacing, because proximal have a better electrical synchrony. Also, in some specific condition, for example, in patients with hypertrophic, proximal is better. And in SCARP, for example, ischemic cardiomyopathy, maybe proximal LB pacing have a high success rate. And also, yes, if placing proximal enough, maybe you have a pace morphology like his bundle pacing. And also, we know his left bundle pacing have a safety. And this is data from our center. Now, more than 3,500 cases, only one patient have a lead fracture, and only one patient with septal perforation. And I have a case with septal hematoma. And this is a population we found LB pacing is now becomes the main pacing mode. And also in China, 15,000 cases in 2023. And also now we have a guideline consensus. Yes, China published the first consensus on conduction system pacing, and now we know conduction recommended only, the class is only 2A. But we know conduction changes the idea, not cardiac resynchronization. We know cardiac synchronization, not resynchronization, because it can be used to preserve in narrow class complex, not like by pacing. This is data, it's very clear. By pacing cannot preserve in narrow class complex. And we have many more and more clinical trial will increase the recommendation level for conduction system. And or in early stage, yes, conduction system can be used early stage to avoid heart failure. In potential indication, for example, sick sinus with left bundle block with normal ejection fraction, yes, we can use conduction system pacing. And this is our first case. After 7 years, battery depression, so we degraded from CRDD to DDD only. Yes, maybe we have a special ICD lead to achieve left bundle pacing. This is ongoing, clinical trial ongoing. I believe this will change the guideline and increase the recommendation. Yes, This is ESC clinical consent statement. And this is Chinese expert consensus on left bundle patients now are writing. I'm so pleased I win fund in 2023 HRS. Thank you for your attention.
Weijian.
Thank you very much, Dr. Huang. First of all, I invite to the audience to make some questions to our first Dr. Lozano from Granada, Spain.
Thanks. My question for Dr. Curila. Can you explain the advantage and disadvantage between ultra-high frequency ECG and QRS area technique, and your opinion about maybe both techniques could be complementary?
Yes, I believe QRS area is a very nice measure of ventricular desynchrony. It measures it in the way that it believes that LV is much more included in the QRS complex than the RV. And the results, we have clinical data showing it's predicting the outcome of patients after BCRT. The problem with the QRS area for me is its number. With the number, you don't see what needs to be improved. So combining QRS area with ultra-high frequency ECG might be perfect idea, because if the number is not optimal, then you might look for ultra-high frequency ECG. Where is the problem? Is it the septum, LV lateral wall, right ventricle, which needs to be optimized? So maybe combining these two measures of desynchrony might be of some additive value, but we need to explore this in the future. But very, very good idea.
Thanks.
Thank you. Dr. Fernández Portales from Cáceres, Spain, also.
Yeah, if I can make a comment. I totally agree with Karol. I mean, high frequency ECG is leading you to understand where are the problems from the physiological point of view and how to correct them. QRS area is much more for investigational point of view and see after. It's not a guide for implantation. I mean. Yeah.
First of all, I want to thank to Dr. Huang for all the support to us in our beginnings. I want to ask, do you use mother and child in 30% of your cases? The CS sheet for the engage to the septum? Mother and child, your technique to gain support to the septum, 30% of the cases?
Yes, CS is very useful. CS sheath is very useful. We can perform, it will be useful in patients with large heart, and also give us strong support for us easy to screen deeper. And also, I just tell what is to reduce incidence of right bundle branch injury. And also we have an accurate or precise position for left bundle patients. So very useful.
Thank you very much. For Curila, do you think we can use your technique for, when we are screwing in the septum to see when it's enough? Because sometimes we are concerned about how deep are we going, and if one turn more is too much, and we go to the other side to perforate the septum. Is effective to predict when to stop, when you see there is a good resynchronization?
So I'm not sure if I can give you answer to that. So we have not been studying in this way. I believe not. It cannot be used. I think it cannot be used for this because the ventricular desynchrony, it's patient-specific. So you can have left bundle branch capture, for example, and you still see that the synchrony is not so good as in the other patient. You have left septal myocardial pacing, okay? So I'm not very sure if the ultra-high-frequency ECG could give you this answer, and it's not dedicated to that. It's dedicated to show ventricular desynchrony. So I'm not sure to answer. I cannot answer now.
Thank you. Pablo?
Yeah, my question is also for Karol. Have you checked the effect of anodal capture in the interventricular desynchrony?
Yes, that's the great question, and we have been studying that and published already last year in patients with bradycardia, which have left bundle branch capture confirmed by the transition. This is the only method we believe works to confirm left bundle branch capture, as Dr. Huang said. So in those patients, if you start anodal pacing, you will reduce interventricular desynchrony, and you don't worsen LV synchrony. Okay, so at least from the data from ultra-high-frequency ECG, doing anodal capture with left bundle branch capture is a good way to go. The average threshold is 2.6 volts in our lab for anodal capture. So if we program 3 volts, then it might work for many patients.
And so the second question is, which concern should we have about having anodal capture regarding clinical consequence?
Yes, so this was not studied properly, like systematically, but from the cases I did, you should be concerned using anodal capture in those patients where you do not have perfect LV activation. So that means maybe left septal pacing in some patients with the slow conduction. When you pace the RV septum ahead of the LV, you will have right to left desynchrony. And for sure, this is much more true for patients with the heart failure and enlarged left ventricle. When you have enlarged left ventricle, 70 millimeters, and you are capturing left bundle branch, the LV synchrony is not perfect because also you are capturing left bundle branch. The distance to travel is quite long. So doing anodal capture in those patients, it would result in right to left desynchrony, not because the LV is diseased or the capture is wrong, just because the left ventricle is so large that even using the highway, that is the LBB capture, is not good enough to perform very fast activation of the left ventricle. So in these two situations, bradycardia patients with left septal pacing and in the heart failure patients with enlarged ventricles.
Thank you. Any other question from the audience?
Francesco, a question for you. You know that I am still a strong supporter of his bundle pacing, but in cases that his bundle pacing do not correct left bundle branch block, do you think that the so-called hot CRT had some indication? Because for me, it's not perhaps lot CRT, yes, but hot CRT?
Well, thanks, Pablo. I think that we have to probably, I asked Karol how to get this wonderful system. I think it's a very easy and simple way to understand where is the problem, how to correct. So probably I don't have now answer to your question, but for sure, if you do not correct immediately, you can mix up and so do hot lot or hot CRT or lot CRT. But I would like to have some tools that tell me where is the problem and how to solve it.
Any other question from the audience? No? I want to ask two questions. One question is, I like fantastic presentations and fantastic speech. I want to maybe with condition system pacing, we have to forget about the narrowing of the QRS, unless it has to be the his bundle pacing, because this is an idea from CRT, when we compare CRT, and we saw that in the slide, maybe we have to take into account if we can get a very, very narrow QRS, that maybe we have to check about the QRS morphology.
Yes, so, but then there is a problem that the QRS morphology, which is for somebody nice, is ugly for the other. So that is qualitative assessment of the QRS complex, and we know it's problematic.
Okay. And another question is, we have to kill the CRT? But I don't know. Because we have already published, I don't know if we are, when we are talking about CRT, we are talking about 30% of non-responder. But there are many, many factors, because you implant in white QRS, left bundle block, intraventricular conduction disease. We have published this already, a randomized paper about level at about 70 patients, and we see that we don't see any difference in electrical activation time, measuring by non-invasive FSCGA by the cardiac side, clinical response, left ventricular improvement. Maybe it's not to try to say left bundle patient, CRT, or maybe you have to take the patient and summarize, maybe it will be better to CRT or to left bundle patient. That's my question.
Maybe it's for you, Francesco, because you did very nice studies about BIV, CRT, and I quite expect what you are going to say.
Well, we did a lot of acute measuring, and of course, if you have a delay and you can measure, but again, we need, that was really time consuming and too much invasive, I mean. At that time, we put a radio wire, so a wire inside left ventricle. Now, I know that you are measuring peripheral with the ZAC, with the system. Yeah, I try to get from ZAC the same system just to have a non-invasive, well, less invasive. But again, we need to have a simple but real method to understand that. That's.
My opinion here is the patient selection. If you select proper patient with desynchrony, doesn't matter if you perform BIV CRT or left bundle branch area CRT, both methods will work perfectly. And I believe you can confirm, Dr. Huang, your paper on LBBP versus BIV in non-ischemic myopathy patients with the his bundle pacing. In the paper, you can read that in those patients who failed with the his bundle pacing, you implanted biventricular pacing. And when you look at the outcome, BIV pacing in your patients was as good as the his bundle pacing. So the patient selection, in my opinion, is the main question.
Yeah, his bundle pacing and the left bundle pacing will have a high percentage of super response and the early response to pacing. Much different. Yes, it's very clear. Conduction system will have a narrow curve complex. That means maybe, sure, better electrical synchrony. It's very, very clear. But in the center, for most of the patients, for example, with a narrow curve complex and the typical left bundle branch block can be corrected by his bundle pacing. We just use one pacing lead to get electrical synchrony, not a resynchronization, because resynchronization is just for wide curve, for example, pacing or pace the curve compressor or left bundle block. For narrow curve, it cannot be used resynchronization. So cardiac synchronization include preserve and restore. So conduction can be used to preserve, but BIV pacing only be used resynchronization, much different.
Another question.
Yeah, but also when we combine the target zone with what was the electrical delay and increase in the PDT, and we follow up the patient. Was not a big, not randomized, but the response rate was more than 80, approximately 90% of responders. So for that point of view, array synchronization works very well. If you also select where to pace during, so that's why my final slides was we have to understand, and there are many tools that can correct, and probably many others are going to probably leadless. Yeah.
The next question will be to Professor Huang is what would need to improve the percentage of successful implants? Maybe new catheters, new leads, new, I don't know.
One word. This is for you.
What in your sorry, no problem at all. In your experience, what do we need to improve the success rate of implants? Because when we are talking about CRT patients, in left bundle patient or his bundle patient, is the success rate is 80%, no? 80, 82?
80% of with left bundle patient.
Yes.
Yeah.
But
20% with his bundle patient. For example, I think it's maybe according to technique, maybe according to criteria for acceptable his bundle patient left bundle. In a set, we have a very strict his bundle patient. The threshold should, the criteria for his bundle should be met with the following. One, pacing beyond the block, it should be very clear. Second, we have a low and stable threshold. We should have a lead stability test. That's very important. And also, in a center, we should have ventricular activation by his bundle pacing. That means we should obtain current of injury local myocardium from his bundle pacing lead. That means we should pacing lead distal his bundle area at ventricular site. But sometimes I prefer the pacing lead at HU for patients with not pace dependent patients. And also sometimes we should choose his bundle patient for patient with IVCD, but the course duration is not very wide. For example, just 112. We think if it can be preserved, it's okay. But in this case, pacing at the left bundle end will result in very wide curve complex, but the process is much better. And sometimes we use his bundle pacing to obtain the level of AV block and to see whether LBB can be corrected. That will tell more information to guide us to perform left bundle blending. For example, complete correction. Then we should have a true LB capture and very nice paced morphology. And also it can be used for EP study to confirm whether the true LB capture. For example, if we have a retrograde his bundle pacing with very short interval, that means true LB capture. So in a center, we have a 20%, but much different with previous report because the surge is very, very high. 3 volts at 1.0 millisecond, but no, must be believed 1.5 volt at 0.5 millisecond, much different, usually less than 1 millisecond. So our data showed threshold for his bundle very stable because we have a multiple choice, multiple option. We can choose elbow pacing instead of his bundle pacing. So his bundle pacing now have can be option. We realize individualized option for conduction system for individuals.
Thank you.
So, any question more, or Pablo, do you think it's time to, or another question, or to finish? What do you prefer?